Shannon, should we start or give it a few minutes?
I think we can get started. That'd be great. Thank you.
Hi, everybody. Welcome. My name's Avnish Mehta. I'm the primary care cancer screening lead for the region. It's nice to meet everybody, and thank you, everybody, for coming today. I think we have a very interesting presentation planned for today. Just to let everybody know, these presentations are going to continue now on in the fall, and we have two planned for the fall, which we're still firming dates. We'll have Dr. Lee presenting on PSA screening in likely September, and Dr. Iqbal presenting in October on alcohol as a carcinogen. So we have some interesting topics coming up as well. I'm going to turn it over to Shannon, who will introduce our speakers today.
Perfect. Thank you so much. And thank you very much to our speakers. Today we have Deb Verban, who's a senior genetic counselor, and Alana Wisniewski, who's a genetic counselor from the clinical genetics program here at Lakeridge Health. They're going to be discussing with us how to optimize genetic testing for cancer screening. And I think just a little bit of housekeeping. We are recording the presentation just to make it available online. And if any one of the participants are looking to utilize this session as a CME credit, please just make sure your full name is displayed by your name bubble. If not, we can't properly issue those participation certificates. So if you see your name is not fully displayed, just please put your name in the chat so we can capture you appropriately. And we will have time for questions at the end, and I'll pass it over to Alana to get us started. Thanks.
Thank you for the introduction, Shannon. As Shannon said, my name is Alana. I'm one of the genetic counselors in the clinic at Lakeridge Health. I'm going to start off this presentation and then I'll hand it over to my colleague, Deborah. We've titled this presentation Breaking News on Hereditary Cancer Testing in Ontario, Who, What, Where, When, and Why. Some people in the audience may be familiar. There have been some big updates to hereditary cancer testing in the province, so it's a very exciting time for hereditary cancer genetics. So we wanted to use this opportunity to first start by reviewing some basic principles of hereditary cancer and then delve right into some of the updates and how we can optimize care for patients in primary care when it comes to hereditary cancer. The basic aims of this talk are who and when to refer to genetics, what will be tested, including what genes, what new panels are available, where we were when it comes to hereditary cancer, where we are right now, and where we see things are going, and then the why component in terms of risk management and how hereditary cancer genetic testing can help mitigate risk for patients, screening protocols and surveillance, therapeutics along patients' cancer journey, and then, of course, the implications to family with some of this information. Many of you may be aware that most cancer is not hereditary, so the vast majority of people we're seeing in genetics do not have an identifiable single gene mutation. About 5 to 10% of the population with cancer will have a single gene cause to explain why they've developed cancer or why a significant family history of cancer exists. The biggest proportion of cancer falls into this blue section of the pie chart, which is sporadic cancer. And there's various risk factors for sporadic cancer, the biggest one being age, and then some other risk factors, including hormones, age at first period, if you've had children, and these are risk factors for breast cancer specifically. And then there's a portion, 15 to 20%, that fall into this familial cluster, when there's more cancer in a family than we'd expect by chance alone, but there's probably some shared genetic and environmental factors in this family, but not an identifiable single gene mutation. This figure here depicts the two-hit hypothesis, which again, some of you may be familiar with. How sporadic cancer happens is there's a normal cell with 2 working copies of a cancer predisposition gene. And throughout time, one copy gets mutated, that mutation is acquired, and then multiple other mutations can be acquired to cause an individual to develop cancer. Whereas in hereditary cancer, an individual is born further down in this process in that they have a mutation in one copy of a of a cancer predisposition gene. This person's not bound to get cancer, but they have a much higher risk than the person who has to go through multiple steps in the non-hereditary type of cancer. When we're looking at family history, certain things that are red flags to us in genetics are definitely how old someone was when they were diagnosed with cancer. As a general rule of thumb, cancer diagnoses under the age of 50 are more concerning for an underlying hereditary cause than cancers that are diagnosed after the age of 50. We're also looking for certain patterns of cancer in a family. So some of you may be familiar with the BRCA1-2 pattern of breast and ovarian cancer, but there's various other patterns we're looking for as well, such as colon, uterine, ovarian for Lynch syndrome. We're also looking to see if individuals were diagnosed with more than one primary cancer or if they've developed bilateral disease. More rare cancers, such as pancreatic cancer or, for example, pheochromocytomas. Individuals of certain ethnic backgrounds, such as the Ashkenazi Jewish population and breast and ovarian cancer or GI cancers in the family. And then lastly, the metastatic cancer category. So we are now seeing more and more patients in this grouping, not only because there's an increased risk to have a hereditary gene mutation, but there also are some therapeutics now that are available to this population. When we're taking a family history in genetics, we definitely want to get 3 generations wherever possible. And we definitely want to also know maternal and paternal side, as they equally play a role in an individual's risk to develop cancer or to have a hereditary gene mutation. We want to know how old people were when they were diagnosed, and we definitely want to make sure we're differentiating between primary cancer sites and where cancer has spread, because in genetics, only the primary site is really what matters to us in terms of familial risk. We also want to make sure we're defining relationships in families. So making sure when people are referring to their family members and aunts and uncles, making sure that these are biological family members and not family members that are married in. As well, we want to make sure some people refer to certain family members like aunt or cousin, but this person really may have a different biological relationship to the patient. So we want to make sure we're defining biological relationships. We want to know if there's any consanguinity in the family, as obviously if parents are related to each other and there's cancer on one side, that cancer risk is coming from both sides, so risk would be higher. And then we also want to know ethnic background, as that can play a role in certain genetic mutations we may see in certain populations. Autosomal dominant inheritance, I'm sure, is a concept that many of you are familiar with. Genetics 101. So just a quick review, we have thousands of genes. For every gene, we get 1 copy from mom and 1 copy from dad. And so a big subset of our genes are cancer predisposition genes. And so as this figure depicts, if somebody like the father in this picture is born with 1 copy of a gene mutated, but has the other copy working just fine, and the mother has no mutations in either copy of the same gene, every time this couple goes to have children, there would be a 50-50 chance that these parents would pass down the genetic mutation. And when we're doing genetic testing, there are various possible genetic test results we can receive. Definitive or informative results are when the person in front of us has cancer or a significant family history, and we've identified a disease-causing mutation to explain the history. A true negative result would be there's a known mutation in a family. We test an individual from that family and they are negative for the known mutation. Then we can say they have not inherited that risk, that increased risk in the family. The more common genetic test results we get are the uninformative ones. So when we test somebody who has a personal or family history of cancer and we do not find a genetic mutation, we need to be cautious in this group to make sure that we're still managing patients based on their personal or family history of cancer, and that a negative genetic test result does not mean they do not have an increased risk to potentially develop some other cancers. And then the more and more genes we're looking at, the higher the likelihood of finding uncertain changes within the genes. When we find these, we typically don't change management for the patient. We often don't test family members, but it is important that this patient keep in touch with us every 2 to 3 years as genetic testing is evolving and changing, and as time goes on, sometimes the lab can reclassify these variants. When it comes to hereditary cancer testing, up until about mid-2021, we were working off 2002 criteria for BRCA1 and 2 only. As many of you are aware, we're testing for many more genes today than just BRCA1 and 2. So using criteria that only looks at BRCA1, 2 risk is obviously not so sensitive for all families with different cancer risks. And then we were also working off of BRCA1, 2 mutation probability of 10%. So what that means is some patients who didn't meet testing criteria, there was an additional criteria to say if you use a mutation calculator program and the risk comes out for BRCA1 and 2 specifically of greater than 10%, you can offer that patient testing. And we've changed this 10% more recently, and that's allowing us to test quite a few more patients that were previously ineligible for testing. And then when it comes to the colon population, we were working off of 2005 criteria, which was specific for Lynch syndrome, and then the APC and MUT-YH polyposis genes only. So again, as you can imagine, there's many other genes that play a role in colon cancer and colon polyposis or GI polyposis, and other GI cancers as well. And so this new criteria accommodates for that as well. Now we have criteria for disease-specific sites, such as gastric cancer, pancreatic cancer, pheochromocytomas, and we also have disease site-specific panels, which allows us to test specifically for the genes we want to be testing for, reduce the chances of unclear variants, and we have criteria for these cancers that we used to sometimes have to send testing out of country for. Genetic testing for hereditary cancer has become more and more important when it comes to patients' cancer treatment plan. So when it comes to surgical management, if we can have a genetic test result before a patient undergoes surgery, this can definitely help in terms of considering this in the surgical plan for the patient. For example, with breast cancer, without genetic testing, many patients may undergo lumpectomy and radiation. With genetic testing, they could undergo bilateral mastectomy as a front line of surgical management. And then PARP inhibitors has become a big role in the in the invasive serous ovarian population and the metastatic prostate population. And this is specifically a treatment that I'll talk about in more detail, but is available to individuals with hereditary gene mutations. We're also now using better technology for genetic testing, so next generation sequencing or NGS technology, which is much more sensitive than the technology we were previously using for genetic testing. We're seeing more and more use of somatic testing, so doing genetic testing on tumor samples, and this can definitely help facilitate germline testing depending on what the results of the somatic testing show. I just mentioned previously the 10% BRCA1, 2 mutation threshold. We're now working off 5%. So we are getting many more patients in for genetic testing, and this works for the affected and unaffected populations. And not only are we getting more people in, we're also not only calculating risks for just BRCA1 or 2, but there's a few additional genes that are included in that risk calculation. And then we also have a colon risk calculation program that's not great, but it is available. And then lastly, more and more, we are offering carrier testing to reproductive partners of individuals who carry autosomal dominant cancer predisposition genes, mutations, because we are learning more and more of these dominant genetic cancer predisposition syndromes can actually also predispose to autosomal recessive, quite severe childhood diseases. So anyone in reproductive age group who has a hereditary gene mutation that is associated also with a recessive disease risk, we are seeing their partners to offer carrier testing. So as I mentioned, I talked a little bit about PARP inhibitors. This is just a brief explanation of how the PARP inhibitors work. The BRCA genes play a role in homologous recombination, so they repair double-stranded DNA breaks. And then the PARP gene plays a role in base excision repair. So when BRCA is working and PARP's working, cells are able to repair themselves. If BRCA isn't working, but PARP is back up there working just fine, again, the cells are able to repair themselves. When BRCA is working, but a PARP inhibitor causes PARP not to work, again, the cells are still able to repair themselves. But cancer cells that carry a BRCA mutation and then have a PARP inhibitor introduced to block the PARP gene, they have no more backup function to repair DNA, and that causes cell death, and that's the target of what we want for cancer cells. So this is why PARP inhibitors are working so well in the BRCA positive population. Specifically, OHIP's funding PARP inhibitors in the context of high-grade epithelial ovarian fallopian tube or primary peritoneal population, and then also in the metastatic castrate-resistant prostate population. Now, the BRCA mutations can be present either in the germline or somatic, and actually for this ovarian population, it is a frontline reflex test on the pathology samples. With the prostate cancer, that's happening less so. So we're trying to see these patients as quickly as possible in genetics so that they can have this information for their treatment plan. And then it's important to note that the ATM gene as well with the metastatic prostate population allows them to be eligible for the PARP inhibitors. We do know PARP inhibitors do work in the breast cancer, pancreatic cancer population with BRCA mutations. Currently not covered, but there are some private pay options available. So if this is an option for a patient, we again try to see these patients as quickly as possible as well. Now, the CanRisk program is a newer program that's available to us to establish mutation probability as well as breast cancer risk. And so we often see patients in genetics referred a lot of the time from primary care who are unaffected, have never been diagnosed with breast cancer, but they're getting referred mainly to see if they qualify for the high-risk breast cancer screening program, which includes mammograms and MRIs every year. So as you can see here, this is an unaffected 41-year-old woman with a mother and maternal aunt who were both diagnosed with breast cancer. So in the process of assessing this patient to see if she qualifies for high-risk breast cancer screening, we've also identified her risk to have a BRCA1, BRCA2, PELB2, CHEK2, ATM, RAD51D, C, and BRIP1 mutation is greater than 5%. So with confirming some pathology on family members, we can then offer this patient unaffected genetic testing based on the new criteria. And as I mentioned, I would talk a little bit about some of the recessive disease risks. So as many of you are familiar, if both parents are carriers for a recessive disease, they have a 25% chance to have an affected child, 50% chance to have a child who's a carrier, and a 25% chance to have an unaffected child. And so in this specific scenario, when we're thinking about autosomal dominant cancer genes, both parents in this scenario would have a risk to develop adult onset cancers. 50% of their children would be at risk to develop that as well, but 25% would be at risk for some recessive conditions, such as these. BRCA1 and 2 specifically, as many people are familiar with these genes, confer a risk for autosomal recessive Fanconi anemia. The Lynch syndrome genes predispose for autosomal recessive risk of constitutional mismatch repair deficiency. So the important thing with these recessive diseases is they tend to be more severe than the autosomal dominant cancer risks. They tend to result in childhood cancers, leukemias, lymphomas, and some significant medical concerns in children. So it's ideal if someone is identified to carry a dominant one of these, for example, gene mutations, that we offer testing to their partner, ideally in the preconception period, sometimes in the prenatal period, so that they do have, they're able to make some informed choices regarding prenatal diagnostic testing, or maybe even pre-implantation genetic diagnosis. Mainstreaming genetic testing, just to switch gears here a little bit, is something where it's an emerging topic. It was presented in the new 2021 guidelines. Essentially, how mainstreaming genetic testing works, specifically in the cancer population. The referring specialist would be an oncologist, a radiation oncologist, or a surgeon, and they're essentially ordering genetic testing on a patient who meets very specific criteria, and this pathway is established in collaboration with the genetics clinic. We have launched this very recently in the past month for the ovarian cancer population, and we worked closely with our gynae oncologist to establish this pathway. And I think genetic testing is going in this direction more and more in the future. We're not quite at the point yet where all physicians are ordering this testing and sending to genetics, but hopefully once we work out some of the kinks in this pathway, I think it's going to be more widespread, and we'll definitely be sure to share some of this information with you as it evolves. And then there's always a portion of patients who fit under this category where maybe OHIP isn't funding genetic testing for them. They want genetic test results quicker, whatever their reason may be. They want to access private pay genetic testing. And so we have a resource on our website called Private Pay Genetic Testing for Hereditary Cancer. So if any of your patients do have interest in this, feel free to direct them to this resource. We are happy to see these patients in genetics if they do receive a positive result from private pay genetic testing to help facilitate management and provide some genetic counseling. We don't need to see all the patients who come back negative or who have unclear variants, but if there's another indication for them to see us in genetics, such as assessment for the high-risk breast cancer screening program, then most definitely send the referral our way and we can assess to see if the patient needs to be seen by us. I'm going to hand it over now to my colleague Deborah to go over some of the specific updates in the new criteria.
Thanks, Alana. Hopefully everyone can hear me. So this document is what sort of triggered this talk today. In the last year, Ontario Health, Cancer Care Ontario, published and launched their new cancer testing eligibility criteria, along with defining more clearly the panels or the groups of genes that will test for specific indications. And so what I thought I would do is sort of highlight the way that this document, what the implications this document has for patients that you might have in your practice. And so what changed? So old criteria, 2002, I believe it was the breast criteria. If you were a single person with breast cancer, you had to be diagnosed before the age of 35. Now that age is bumped up to age 45 or sometimes 50. And if you have triple negative breast cancer, it's as high as age 60. So you can appreciate that there will be a significant portion of women who are now eligible, who were not previously eligible for genetic testing. In our old criteria, really the criteria were very focused on breast and ovarian cancer, whereas now the tumor spectrum that we consider in terms of determining eligibility includes pancreatic cancer, prostate cancer. And before the criteria were really quite tightly defined, very little sort of wiggle room. You either met OHIP criteria or you didn't, whereas now there's a little more flexibility to take into account things like family structure and whether the patient is adopted. And as Alana already pointed out, the threshold at which we can offer testing has dropped from a 10% mutation probability to now a 5% mutation probability. So that's for the breast ovarian patients. For the GI cancer patients, in the past, the hereditary GI cancer testing really focused heavily on colorectal cancer. And focused on Lynch syndrome. There are 5 genes associated with Lynch syndrome. And there was a 2-step testing process if the family met criteria. And the criteria were quite strict. There had to be a young age of diagnosis, or at least 3 people with colon cancer in a first or second degree relationship with each other. And the testing consisted of tumor testing and then only moving on to germline testing if the tumor testing was suspicious. So what's changed in terms of the tumor testing is that as of August of last year, anybody with a Lynch type cancer, doesn't matter how old they are, will get tumor testing. And so many, many more people having tumor testing, many, many more positive tumor testing results. Like I mentioned, the focus on colorectal cancer has changed. So there is a widened spectrum, and there's also specific testing and specific panels for multiple types of GI cancers and GI cancer combinations. So colon, uterine cancer, gastric and lobular breast cancer, gastrointestinal stromal tumors all have specific testing that we can offer. And in the past, the GI polyposis syndromes focused on adenomatous polyps, and you needed a minimum of 10 sort of pathologically confirmed adenomatous polyps to offer testing. And now the polyp spectrum has increased, so other polyp sites and other types of polyps, like serrated polyps and hematomatous polyps, as well as other non-GI findings, hepatoblastoma, changes in the eyes, desmoid tumors. And again, just like with the breast, whereas in the past there's no accommodation for clinical judgment and family structure, we have kind of a not great, but a mutation probability program that we can use, and there is some room for clinical judgment in there, a 5% threshold to kind of offer testing. Again, prostate cancer, in the past, no provincial guidance at all. There were clinics sort of doing testing on prostate patients just based on what they felt was appropriate. And most men with prostate cancer didn't qualify or didn't get referred or were not seen for testing. And now we have specific prostate criteria, most important of which is a personal history of metastatic prostate cancer. And this is really driven by the fact that there was a recognition that the PARP inhibitors would be helpful for therapeutic treatment in this group of men if they carry a mutation in either one of the BRCA genes or in the ATM gene. And then there is a criteria based on high-risk prostate cancer, and there's some sort of guidance about what high risk looks like. So basically a Gleason score of 8 to 10, PSA levels to guide that. Or if there's a family history of prostate cancer with another relative having a high-risk prostate cancer, or 3 people with prostate cancer in the family, that'll get you in. And as I mentioned, what they found was that in some of these metastatic prostate cancers, they were finding in the tumors high rates of these homologous recombination repair gene mutations, and that a proportion of these would also have these mutations in their germline. So it was kind of a backwards way of doing genetic testing. It started off as a therapeutic implication and then realized that there are also familial implications for these patients. Pancreatic cancer, in the past, no provincial guidelines, just a clinical judgment. And as you know, based on the survival rate of pancreatic cancer, many individuals didn't even make it to be referred to genetics and didn't undergo testing. And luckily, right now, the criteria for pancreatic cancer is very simple. Any individual with a pancreatic adenocarcinoma at any age is eligible for genetic testing. And then there's specific criteria, as Alana alluded to, for rarer cancers and unique situations. So Ashkenazi Jewish, individual with breast, colon, and or GI polyposis, people with pheochromocytomas and paragangliomas. There's specific criteria for renal cancers based on age at diagnosis, family history, and bilaterality, testing for gastrointestinal stromal tumors, specific criteria for melanomas, particularly an individual with an eye melanoma is immediately eligible for testing, and then some criteria for CNS tumors and sarcomas as well. And so what are the implications for people in primary care? Well, we would certainly hope that any new cancer diagnoses should be flagged for referral to genetics by the oncology team. But you may have patients in your practice that meet new criteria that didn't meet the old criteria. So some of your historic patients may need a second look and updated testing. There may be new testing indications that they fit into. There may be changes to their family history, or all of a sudden their family history as reported makes them eligible for testing. And when you're doing the family history, or when you're seeing these patients for their annual physical and you're reviewing the family history, you need to think about not just breast ovarian cancer, breast ovarian colon cancer, but think about prostate cancer, pancreatic cancer, uterine cancer, other polyposis, other gynae cancers is important. So having as full a picture of the cancer family history as possible is always going to be helpful. And having the pathology can be very helpful in determining eligibility. And, people tend to switch family doctors as they get older. Their family doctors retire. Sometimes you acquire a patient who maybe had prostate cancer 10 years ago. Maybe you don't have those records, but it is useful to get those to say, was it a Gleason 8? Maybe this patient is eligible for genetic testing, and that might be helpful. I'm going to switch gears and talk a little bit about breast screening, because this is the area in which we depend a lot on the support of the primary care and in making appropriate referrals, and where you depend on our support in providing recommendations. So in Ontario, the breast screening is covered by the Ontario Breast Screening Program, and that's existed for a really, really long time, I think since the 80s. And the average risk program is available to any woman between the ages of 50 and 74, and consists of screening mammogram every 2 years. And women can self-refer. I had a patient this morning who told me she's 70. She told me she hasn't had a mammogram because she doesn't have a family doctor. And I said to her, you can refer yourself for a mammogram. And sometimes women with a first-degree relative with breast cancer or a significant family history are advised to start their mammograms 10 years earlier, or to maybe be screened every year, depending on what's seen on their mammograms. So that program has existed for a very, very long time. In 2011, the Ontario Breast Screening Program introduced the high-risk screening program. And the high-risk screening program was designed to offer enhanced screening to women whose risk is significantly elevated from that of the general population, while sort of conserving that resource for people who really need it. And so it's available to women who have a 25% or greater lifetime risk of breast cancer, and Ontario Health defines that as risk to age 80. In order to be evaluated, women must be between the ages of 30 and 69, and so they can be screened as early as age 30. And it's aimed at people with a personal or family history of breast or ovarian cancer. And as Alana pointed out, instead of screening every 2 years, the high-risk screening program incorporates an annual mammogram and breast MRI. The important thing with the high-risk program is that the enrollment is based on an assessment, a genetic assessment of risk, and that happens through the genetics clinic. And so it's not as easy, if you want, to get in as it is for the average risk program. In order to get into the high-risk program to be assessed, patients need to be referred. And they need to be referred to the genetics clinic for assessment. And in order to be referred, they have to at least meet a minimum threshold of family history. So this is the section of the high-risk genetic assessment form, referral form, that talks about why the patient meets criteria to be assessed. So there needs to be at least 2 cases of breast cancer in the family, breast or ovarian cancer, or if there's somebody who's had bilateral breast cancers, or somebody who's had breast and ovarian cancer, or somebody diagnosed with breast cancer at under 35, or somebody with invasive serous ovarian cancer, Jewish ancestry with breast and ovarian cancer, or male breast cancer. So the patient either must have one of those themselves or have a family history of that in order to be referred. The referral form, the entire referral form looks something like this. On our left side here, that form might be familiar to many of you, I hope so. They can also be referred with our regular genetics referral form just by clicking on assessment for eligibility for OBSB high-risk screening. So either way, we'll get you a referral into the genetics clinic, and we see these patients all the time for assessment. These patients are seen a little bit differently. Often they are unaffected women, and we start off their appointments by sending them a couple of forms to complete that will allow us to have the information that we need to do their assessment. So the first form is a breast cancer risk factor form, and we ask them questions about their personal risk factors like age at menarche, if they're still having periods, if they've had children, have they had a mammogram, if they've used hormone replacement therapy, etc. And the second form is a family history form, and it's a kind of a quick and dirty one. So the top part of the form allows us to assess the family structure. So how large is the family, how many brothers and sisters, aunts and uncles, who has had cancer, Jewish ancestry. The bottom part is where they give us details about who has had cancer and at what age, and if anybody has undergone genetic testing. You'd be surprised by how many times we do get an answer that yes, and that it is positive, but yet the patient hasn't been seen yet for their own testing. So the patients complete those forms, and using that family history form, we would construct a family tree, or we call it a pedigree. So this is a fictional patient. Her name is Agnes, and this is a typical patient that we might get referred through the high-risk screening pathway. And she's an unaffected 46-year-old woman with no Ashkenazi Jewish ancestry, has a sister who had breast cancer at 45, a sister who died of ovarian cancer. Both her parents are alive and well, but on dad's side, there's a family history of breast cancer in the paternal aunt and prostate cancer in the paternal grandfather. And so we construct the family tree. And then we see the patient and we do an assessment of breast cancer risk using one of two programs. So this program is called IBIS, and it allows us to, and I'm not sure how big this image is on your screen, but you might be able to see that at the top here is all the information we input about the woman's personal risk factors. So the questions we asked about if she had children, age at menarche, height and weight, etc., all here. At the bottom here is all the information about the family tree, the family history, who has had cancer, age at diagnosis, and the program actually does construct a family tree itself, focusing only on the women. And then we ask the program to calculate what is the risk that this woman will get breast cancer between now and age 80. So for her, that's 34 years of risk ahead of her. And we click on calculate risk and we get a printout. And the printout tells us that her risk is 22.9%. So you may remember that I said the threshold for referral to the high-risk breast screening program is 25% or greater lifetime risk. And so Agnes would be a patient who would not be eligible for high-risk breast screening. But in doing this evaluation, we're able to give her that information. And we're also able to tell her, hey, 34-year population risk is about 10.3%. Your risk is double that. It's not 25%, but it is double that. And so we're able to share that information and have a discussion with her about, you know, go back to your family doctor, and certainly at age 46, when you've had a sister who is had breast cancer at age 45, you should at least be having mammograms. Because that earliest diagnosis in the family was at before age 50. We typically say 5 to 10 years prior to the earliest diagnosis in the family. And given that your risk is double, you're close to the cutoff for high-risk screening, maybe a discussion with your doctor about considering having screening every year instead of every 2 years is a good idea. So we are able to sort of tailor that risk discussion a bit based on the number we get out of the risk calculation program. we would send back, based on doing that assessment, a notice to the high-risk screening program that this patient at this time, through genetic assessment, was not eligible for high-risk breast screening. And so that's just paperwork we complete on our end. What I do want to draw to your attention is that when we're evaluating women's breast cancer risk using either IBIS or the other program called CanRisk, which Ilana spoke about earlier, there is this section here on mammographic density. And this is a section that only applies if the woman is over 40 at the time of assessment. But we are able to input information, if we have it, about this woman's mammogram. And so going back to that patient, Agnes, I get a mammogram report from her, and it says here, category D, greater than 75%, the breasts are extremely dense, which lowers the sensitivity of mammography. And so this is important information for us to put into the calculations because breast density affects screening choices and screening in a couple of different ways. First of all, if a woman has very dense breasts, they're very hard to see on mammogram. And it's hard to see if there's a cancer there on mammogram. So the sensitivity of mammogram is decreased. And the second edge of that sword is that if a woman has dense breasts, her cancer risk is higher. And so knowing breast density is super important in assessing a cancer risk. And what I'll show you is if I go in here and using the same patient, Agnes, with all the other information being the same, and I enter her mammographic density is extremely dense, and redo that calculation, her risk is now 36.5% to get breast cancer between now and age 80. So now this is a patient that I can appropriately refer to the high-risk screening program, and she will get mammogram and MRI will be a way better choice for her in terms of picking up a breast cancer. So I would fill out the assessment form differently and say that she's been assessed to have a greater than 25% lifetime risk and send that off to the OBSP high-risk screening program. In turn, the nurse navigator from that program will contact the patient to set up their first screen. All the screening reports go back to the primary care physician. So there's a part of the form where I fill in who should get the results from screening, and that's always going to be the primary care physician to follow up in the same way as you would with an abnormal mammogram or anything like that. So we've touched a bit on the new criteria, the high-risk screening program, given a bit of a background, and Ilana and I just wanted to sort of share these take-home messages. So patients in your practice, whether they're unaffected or affected, if they have a significant personal or family history of cancer, they may benefit from a genetics assessment. And certainly the unaffected woman may benefit from an assessment for eligibility for high-risk screening. Just keep in mind there needs to be usually at least 2 people in the family with cancer, or somebody diagnosed unusually young, or male breast cancer or something like that. Patients who have not previously qualified for testing. So you have a patient in your practice who had breast cancer 10 years ago, and you already asked the question, does she qualify for testing? And you were told, no, that may have changed. If you provide as much detail as you can about the family history, it will help your patients get seen appropriately and triaged appropriately. Like all genetics clinics in the province, we have a significant wait time for patients to be seen. And so we try not to see patients that we don't need to see. But if it turns out that we think they don't need to be seen because we don't have all the information, that's frustrating for you, for them, and for us. Please send as much information as you have. So pathology reports on the cancers, if you have screening results, mammograms, colonoscopies, we need to take an eye and see what type of breast cancer did they have. Is there a lobular breast cancer? Is there also stomach cancer in the family? What type of polyps did they have? So all of the information is helpful to us. And both sides of the family matter. So, you know, don't just tell us about the family history on mom's side. Tell us about dad's side as well, but keeping in mind that if you have a patient in front of you that mom and dad both had colon cancer, that's just one colon cancer on each side. Both sides of the family matter in terms of consider all the cancers on one side and all the cancers on the other side. There are some resources available on the Lakeridge Health website, and I have on my radar to update some of those resources in the near future. And the most important, if you have any take-home message from today, is please, if you have questions, just call and ask. The genetic counselors are so willing to answer questions. There is always a genetic counselor on call to answer your questions, and we'd be happy to do so and navigate you through it. We'd rather answer a question about a patient who doesn't need referral than to think that there are patients out there who are being missed, being referred. And I will wrap up there, and Alana and I will take questions. I see a question from Alex.
Oh, yes. I had a patient who was 77 and had bilateral breast cancer, lobular and ductal. And she was refused from genetic testing. Do you have a ceiling on these criteria that make them rejected?
So she had bilateral breast cancer. Was there any other history of cancer in the family?
Not that she knew.
No. So what we often will accept those referrals. Was she seen and she didn't have testing, or was she not seen?
Not seen. Rejected.
Oh, okay. Often we will accept those referrals because and was that within the last year?
Oh yeah, like 4 weeks ago.
Oh. Okay, that might be worth another look because sometimes we can do the calculations on those patients, like Alana said, using the CAN-RISC, and sometimes they do meet criteria, even if they don't clearly meet one of the sort of the itemized criteria, but they may meet that 5% threshold, and so that would be worth a look. I don't know what to tell you. Our genetics email, genetics@lh.ca, is there. Maybe just send an email and request a phone call with the genetic counselor on call. Any other questions? I didn't see anything come up in the chat, I don't think.
I guess the only other thing I was going to say was your fictitious patient, Agnes. If you referred her for genetic screening, would you accept her, or would you encourage her sister, who was positive, to be the one? And what if she refused?
Yeah, so that happens not infrequently. So we would say to Agnes that she should, that we would have said to her in the meeting, your family is eligible for genetic testing, and that testing should best start with your sister. And so, and we suss out a bit what is the family dynamic, and she says, oh, my sister didn't know that. I don't know if she's had that done. Or she'll say, oh, my sister will never do that. She's put her head in the sand type of person. So if she says that her sister will not do testing, we would assess her mutation risk, and I suspect it would be high. And if she is eligible for unaffected testing, we would do it on her. So similarly as if her sister was deceased. The tricky part in those conversations is getting patients to understand that when they are unaffected and have genetic testing, it is less informative than when someone is affected. And I have a patient who contacted me this morning because her mom and her maternal grandmother had breast cancer. She met the 5% threshold. She tested negative, but she now has 3 sisters who want to be tested. And so it's tricky. For those patients, I'm always more happy when they meet criteria for high-risk breast screening, because I'm like, at least you're having the screening that you need, especially if it's a breast-only family. Somebody's got a hand up and I can't see. Anybody else?
Well, that was great. Thank you so much, Deb and Alana. That was fantastic. Lots of information shared, and I think that was quite excellent. So thank you again. Just a reminder for anybody who maybe didn't hear at the beginning, if you don't have your full name in your little chat bubble, just make sure you enter it into the chat so we can assign appropriate participation certificates. And we thank everyone. If there's no other questions, we can close out for the afternoon, and thank you all so much for joining us today.
Thank you.
Thank you.
Thanks very much.